All right, let's get started. Last time we discussed the possible implications of biotechnology and other advances for human health. We talked about the sort of unresolved debate between Sandel and Harris. And we briefly mentioned Jay Hughes's argument about the hand-in-hand nature of technology and democracy for human welfare. We spoke as well about the practical and moral problems raised by situations at the boundary between life and death, between people and animals, between people and machines. And today I'm going to be spending a day talking about a few illustrative policy interventions. We could have spent the whole semester just studying health policy or public health interventions or different sorts of clinically focused interventions that would improve health of the public. Of course, we didn't do that. The course was much broader than that. We have touched on different sorts of policy interventions, but today I'm going to try to highlight a few matters with respect to public policy that's relevant to health, and also spend some time on the important issue of insurance and the availability of health insurance, and whether it makes any difference with respect to the health of the public. Now, it's probably fairly surprising to realize that even now, a large fraction of the American population, probably around 28 million people, lack health insurance. And in 2018, the percentage of persons uninsured at the time of the interview was about 9%. So, the most recent year we have statistics, about 9% of Americans didn't have any health insurance. And this is completely different from every other industrialized democracy. And this fact, coupled with the manifest inequity and inefficiency in the system, prompted the passage of the Healthcare Reform Act of 2010, when you were all in elementary school, which finally made a dent in our numbers. We had for many, many decades been the country with the lowest, of the rich countries, the one with the lowest levels of people who had some kind of access to health insurance. And finally, in 2010, with the passage of the ACA, we fixed that, we addressed that, but still not completely. And now, it's also important, by way of backdrop, that you realize that when we speak about this topic, almost everyone in the United States, over 96% of people who are older than 65, already are beneficiaries of a nationalized health insurance program, namely Medicare. So if you're older than 65 in our country, for over 50 years, you have had access to a kind of public insurance automatically when you reach the age of 65. So all the politics, all the debate in the last 50 years has been about whether to do something similar for younger adults. And finally, about 10 years ago, as I mentioned, we did something, although still, as I just mentioned, 9% of Americans are not covered by health insurance, which is a problem. This lack of insurance varies by age. As I just mentioned, if you're older than 65, with very few exceptions, you're covered automatically. So there are very few people older than 65 who are uncovered by insurance. And then if you're 0 to 18, you're also often covered, although there's some other wrinkles there. And the lack of health insurance is primarily a problem of working age adults. Some of you will go into occupations after you graduate that don't necessarily come with insurance. Maybe you'll take a year off and you won't be on your parents' insurance. Maybe you'll work as a painter or a farmer, or maybe you'll try to start your own business or a startup, and there are just 2 or 3 of you in the startup. You will have no automatic health insurance in that type of situation. Health insurance comes with employment often in our society. So you would be uninsured. And while the necessity of health insurance would be very low, and if you're a 22 or 24-year-old person, you're unlikely to have some kind of catastrophic illness. But if you did, if you were hit by a bus, you would have no access to health insurance to provide for your medical care. Either you would suffer a financial catastrophe, or your friends and family would have to use up their wealth to care for you, or after your initial treatment, you'd be on your own in terms of trying to pay privately for your medical care. So it's a problem, lacking insurance. in our society. And incidentally, it also, in my view, interferes with the economic efficiency of our society because it often connects workers. People will stay employed in a particular place just to have their health insurance, even if they could be more productive somewhere else, in a way that if we provided a kind of public option, labor could move around more easily from place to place, which would enhance economic efficiency. Interestingly, however, despite the scenario I just gave you of a person who doesn't have a conventional job lacking health insurance, it turns out that most people who lack health insurance actually are employed. And that's because the typical job is not like the ones I was describing for you guys. The typical job is a job where people are working part-time or are itinerant workers or paid by the hour, hourly workers. And those often don't come with benefits. So if you look, for example, at the family work status, most people who lack health insurance have jobs. So for example, for 63% of the people who lack health insurance, one or more members of their family are full-time workers. I don't know, whatever that is, 16% are part-time workers and 21% are unemployed. So most of these people have a job and many of them have significant income as well. And so these data like this have suggested to policy analysts for a very long time that the workplace might not be the best venue or means for providing insurance. And not surprisingly, lacking insurance results in a significant reduction in the access to health care. So this looks at the percentage of adults in your age bracket, 20 to 29, who did not get or delayed medical care because they couldn't afford it. This is now old data, but it's still illustrative. So if you look at across all races and ethnicities, 16% of people in this age group reported not getting or delaying medical care because they couldn't afford it. And there was some grading according to race and ethnicity. Now, of course, by now, we know that there could be, in this class, we know that there could be confounding factors associated both with not having health insurance and with not seeking medical care. In other words, there could be some other factor that explains both of those things. Maybe, you don't like doctors and you don't like hospitals. And so you don't care about having health insurance. And even if sick, you don't go to the doctor. So we need to make sure we have a more subtle understanding of what's going on here. And also, even more important, by this stage in the class, you should be, I hope, properly skeptical about the benefits of medical care at all. We should be unsure about whether medical care is the crucial determinant of health, regardless of whether the person has insurance or not. But as I said, the United States is unusual in its lack of public health insurance for all. And it's also extremely backwards in this regard. All these European countries have had compulsory health insurance, some of them for over 100 years. Germany introduced compulsory health insurance in the 19th century. Greece introduced compulsory health insurance over about 100 years ago. So it's really, we're behind in implementing this kind of public policy. Finally, the Patient Protection and Affordable Care Act of 2010, also called the ACA, was passed and started to address these problems. This act was extremely complicated and it reflected the political realities that were then present. It was not perfect, but it wasn't so bad either in addressing some of the problems that had been very persistent with American healthcare and American health insurance. It required citizens and legal immigrants to have insurance. It created state-based so-called American health benefit exchanges. These are often called the exchanges, through which individuals can buy coverage, and it put into place complex incentives to incentivize people to do that. It had a so-called individual mandate incentivized by a penalty. It said, in other words, if you don't buy insurance with your own money, you're going to have to pay a kind of penalty, a tax, as a consequence. So, you should buy it. And it required employers to provide coverage also with complex incentives, and it expanded Medicaid and Medicare in certain ways. Those were existing systems. Medicaid is for the poor, and Medicare, as we said, is for the elderly, also for people with end-stage renal disease and certain other subgroups. And it expanded those in certain thoughtful ways with the idea of insuring as many people as possible. The financial incentives and penalties were provided so as to avoid the problem known as moral hazard. This is the idea that if you know you're sick, you're going to race to buy insurance, which of course drives up insurance rates and makes insurance unprofitable or impossible to implement. Conversely, if you know you're well, you won't buy insurance. We want to eliminate that idea. We want everyone to be in a kind of same boat, all of us sharing the risk that some of us, through no fault of our own, will become sick, and that buying insurance is in a way almost a public good. Here's how the act was forecast to affect the problem of the uninsured. So this was what was happening in 2010 before the act was published, and this is what was predicted for now. So back then, Medicaid was in this blue, the employer market was this red, non-group other was the orange, and uninsured was the green. And as you can see, the other slices of the pie were predicted to increase. And in the uninsured, the green line, which was the point, was the primary target of the legislation, was expected to be reduced. In fact, on the left, there were 162 million people in the employer market. 54 million were uninsured, 35 million were on Medicaid, and 30 million people were in the non-group other market. And after reform, it was forecast that there would be 159 million Americans in the employer market, 44 million on Medicaid, 25 million in the non-group other market, 24 million in the exchanges, and only 22 million would be left uninsured. And as I mentioned a couple of slides ago, that's approximately where we are at. So the legislation has pretty much had the forecast impact, although still many, over 20 million Americans are uninsured. And in the uninsured category went from being the second largest to the smallest in the last 10 years. And the population that is persistently uninsured now includes illegal immigrants, people who can't afford insurance and aren't getting subsidies from the government to help them purchase it, and people who have decided to pay the penalty rather than purchase insurance. Why you would do that, I don't know, but some people make that decision. And having insurance does actually increase one's use of medical care. And the financial details of the kind of insurance you have can actually influence how much medical care you use. We know this from a very famous but now old experiment called the Rand Health Insurance Experiment, the HIE, which was conducted in the 1970s and involved 2,000 non-elderly families in various locations around the country. And these families were randomly assigned to get different types of health insurance, including free medical care. So this was an actual experiment. The families were randomly assigned to different kinds of insurance where it was either free or they had to pay for 25% of their care or 50% of their care or 95% of the care. So it wasn't much insurance at all. And unsurprisingly, the more people had to pay for their own health care, the less of it that they used. So for example, in-person visits, if they were free, you used more in-person visits, and the more you had to pay for them, the less you did. Hospital admissions also showed this pattern, but a little less steep a gradient because this is an inpatient visit is more volitional than a hospital visit. The likelihood of any healthcare use showed a similar pattern, and the total expenses in 1991 dollars also showed this pattern of increased expenses incurred by people who, could use healthcare for free. So in the Rand Health Insurance Experiment, when cost sharing, that is to say what the patient had to pay, was higher, the use of medical care was lower. But the question is, were the people who used more medical care actually better off? In other words, forget whether insurance affected healthcare use. It did. Did it improve health? And there the story is much more complicated. So we now can look at a number of health measures. This shows free care versus cost sharing. There's a lack of effect on health status. So giving people access to free medical care by giving them insurance where they had to pay nothing for medical care, increased their use of medical care, but had no effect on their health measures, according to these measures. This result should not surprise you by this time in the course, because I hope you are suitably skeptical about the benefits of clinical care in actually advancing the health of the public. If you looked at physical function on a score of 1 to 100, no difference in the free plan versus cost-sharing plan. Mental health, no difference. Smoking, no difference. Weight, no difference. Cholesterol, no difference. Diastolic blood pressure, no difference. Far vision, a slight difference in diastolic blood pressure. Vision slightly improved in the free plan because they got glasses. They wanted glasses and they got glasses. And risk of dying, not detectable. And this is one of the key things we've been seeing throughout the course. This may not make much difference to cover to overall health to provide people with insurance. So in this old experiment, free care had no effect on the major health risk factors that are associated with cardiovascular disease. And while people with free care saw the doctor more often, this did not lead to behavior change or risk factor improvement in weight, smoking, or cholesterol. There was a mild improvement in hypertension, which, as we saw at the population level months ago, in that when we looked at that at the so-called MONICA study, this slight improvement was non-trivial, but still it was small. And we must note, having insurance is not a panacea. So access to medical care, let alone the proper use of medical care, should not be conflated with having insurance. A more recent natural experiment, however, addressed the same topics. The ACA Act expanded Medicaid coverage for low-income adults, but the likely effects of this expanded coverage were unclear. The 2008 Medicaid expansion in Oregon, based on a lottery drawings from a waiting list, provided an opportunity to evaluate these effects. So there was a kind of opportunity to give insurance to the poor in Oregon, and they randomly assigned this opportunity to some poor people and others did not get it. Approximately 2 years after the lottery, data from 6,387 adults who were randomly selected to be able to apply for the coverage and 5,842 adults who were not selected were compared to each other. And the scientists used the random assignment in the lottery to calculate the effect of Medicaid insurance coverage. And they found limited effects on physical health, but notable effects on mental health, healthcare use, and financial circumstances. So once again, this is an experiment. People are randomly assigned the opportunity to apply for Medicaid coverage. This is a primarily poor population. And we find that maybe there was some decline in blood pressure, but it was not statistically significant. No effect on total cholesterol. No effect on diabetes management. This is glycosylated hemoglobin, the hemoglobin A1C that I introduced months ago in the class. There was an effect on depression and on health quality of life rating at 1 year, and on out-of-pocket expenses. The people with insurance paid less. There was also an impact on medical debt, on prescription drugs, on office visits, and on the receipt of medical care. So the pattern is somewhat similar to the Rand health insurance experiment. Increased use of medical care, some additional benefit financially, but not so much benefit on some of the health measures that were looked at in this study that was done more recently. In short, this study also showed that Medicaid coverage generated no significant improvements in measured physical health outcomes in the first 2 years, but it did increase the use of healthcare services, raised rates of diabetes detection and management, lowered rates of depression, and reduced financial strain. And it is unclear if long-term effects would be different. In other words, if we followed these people for a much longer time, or whether in such a poor population, the real threat to health is something else altogether. The reason the poor are sick and dying is not necessarily because they don't have access to health care. Now, I need to be very clear. I am not saying we should abandon the poor and we don't care if they have access to health care. But I am saying that the main driver of mortality and morbidity in the poor may not be whether they have insurance or can use a hospital. But here's another analysis of the benefits of health insurance, examining cancer detection and mortality per 100,000 people among people just above and just below the age of 65. So you can say, well, when you hit 65, magically you're enrolled or can enroll in Medicare. What if we looked at people who are 64 and 9 months old versus 65 and 3 months old and compared those two groups whose age is basically the same and saw whether they died of cancer, depending on now whether they had, just by chance, access to Medicare insurance because they were so close. This study considered 3 tumor sites for which screening is recommended both before and after age 65, at breast, colorectal, and lung cancer. And at age 65, cancer detection increased by 72 per 100,000 population among women and 33 per 100,000 population among men. And cancer mortality also decreased by 9 per 100,000 in women, although there was no significant change in men. So if you look at the detection, here are detection rates going up until you reach 65, and then bang, all of a sudden you have access to insurance. We can detect cancer more easily in you because you have insurance and can use the health system. Something similar, steps up for the men. The mortality effect's a little lower for a number of reasons you can imagine, including the fact that to have an impact on mortality would require a longer time horizon. But there seems to be some improvement in women, but no real change in men's risk of death from cancer when they acquire access to insurance. So the picture is complicated. Here's another finding taken from your readings. The authors evaluated a randomized pilot study in which the IRS sent informational letters to 3.9 million taxpayers who paid a tax penalty for lacking health insurance coverage under the Affordable Care Act. And drawing on administrative data, the scientists studied the effect of the intervention of the IRS sending them a reminder on taxpayers' subsequent health insurance enrollment and mortality. Did getting a reminder from the IRS saying, you know what, maybe you shouldn't be paying this penalty. Why don't you enroll in health insurance? So they're going to see whether the letter had that effect. And then if the letter had the effect, or actually regardless, using what is known as an intention to treat analysis, which I'll skip the details of right now, but the gist is they're going to say, did that letter also reduce mortality? In other words, via the process of increasing your likelihood of getting insurance, did people who were randomly assigned to get the reminder letter from the IRS and thereby perhaps get insurance, did those people survive better? And units here, and in fact, the intervention of getting the letter led to increased coverage in the 2 years following treatment, and this additional coverage actually reduced mortality among middle-aged adults over the same time period. This slide shows the difference in the cumulative mortality taken from your readings between the control and treatment groups. The units are percentage points, and the brackets denote the 95% confidence interval based on standard errors that are clustered on the household level. And this is for individuals between the ages of 45 and 64 at the start of 2017. So what can we say about cumulative mortality comparing treatment to control? Over here, bang, they get the letter. And now we find that actually progressively, the people who got the letter are less and less likely to die. Unbelievable. The government saved their lives by sending them a letter saying, you know what, don't be an idiot. Well, didn't say it that way, but said, you might wish to consider not paying this penalty and signing up for health insurance. And those that did get the letter compared to those that did not lived longer. In the 2 years following the intervention, the rate of mortality among previously uninsured 45 to 64-year-olds was lower in the treatment group than in the control group by approximately 0.06 percentage points, or 1 fewer death for every 1,648 individuals in this population who were sent a letter. So, health insurance increases medical care, probably doesn't improve your health, but it might. It's not a clear picture. Any questions about that before I move on? Yeah. Who's someone raise their
Go
hand?
ahead, Severin.
I'm kind of wondering, maybe I misunderstood something, but based on the earlier data, essentially the ACA provided limited benefits in terms of like death versus no death. However, if the government sent letters
Yes.
asking people to be a
Yes.
part of the ACA, essentially, like that there is a like decreased
Yeah.
death rate.
So there are
Just
different
confused why.
studies with different methods that reach perhaps different conclusions. So I showed you 4 or 5 studies. One was in your readings, the other I just summarized, and it's a complicated picture. It's not obvious. It's pretty clear that insurance increases healthcare use. It's much more difficult to show that insurance improves health materially. Uh, and one of the studies, the last one I just showed you, suggested that it did. The difference between the 2 ACA studies probably relates to their different populations. The Oregon study was for the poor, and the study I just showed you was for people who had chosen to pay a penalty the preceding year. So maybe that's part of the explanation of the different outcome in the 2 studies. Also, one was national, one was in a given state. I mean, they were slightly different. We do, this social scientists do the best they can with the data that they have. Any other questions? All right, well, let's turn to an overview of public policy options to affect public health, some of which we've already explored in the course. So what are the kinds of things that we can do if we want to use levers of some kind to enhance the health of the public? Well, we could pass laws that tax things differently. We could tax unhealthy things, and that affects people's behavior. We could allocate funding for research or delivery, for example. We can pass other kinds of laws, that mandate bike lanes or that regulate air pollution, that have impacts. We could engage in different kinds of education using advertising, public health advertising, or marketing that we are now doing, for example, in the COVID pandemic. We could have different sorts of interventions that are based in networks or communities, whether it's schools or using some of the network methods that I talked to you about a few lectures ago. Or, as we'll also be discussing today, we could do sort of mechanism design. It's not the right term, mechanism design, but we could sort of fiddle with using nudges, the ways in which we present people with options so as to kind of have a soft paternalism where we kind of help them do the right thing without really forcing them. So let's look at some of these ideas for the remainder of today. Maybe one focus should be on increasing healthcare quality. What could we do to make healthcare better? Perhaps what we could do is align incentives between providers and payers and patients by returning money to patients if the healthcare didn't achieve its objective. So one idea, which is actually a very old idea, is to pay medical providers only if the patient gets better. This is known in modern parlance as paying for quality. And whether you believe it, whether you know it or not, many insurers now condition their payments to healthcare providers so that they're only paying for things that work, right? Why, as an insurer, would I give money to a healthcare provider if they were doing superfluous things or dangerous things? If they were still doing double mastectomies when they shouldn't do them, I shouldn't pay for that as an insurer. It's harming my patients and it's wasting my money. So many insurers are now adopting, in a kind of different form, an idea that is really quite old, which is to say, we're only going to pay the healthcare provider, the doctor, if they actually do something that is helpful. So this is an old, of course, ad for patent medicine, Emerson's Bromo Seltzer, all headaches instantly cured or money refunded, right? Or your money back. Actually, such a thing can, good old-fashioned American capitalism can align incentives in a way that might be beneficial. But as I mentioned, this is a very old idea. This is a contract between a patient and a doctor from Genoa in the year 1244. And it reads like this contract. In the name of the Lord, amen. I, Rogerio de Bruck of Bergamo, promise and agree with you, Basso the wool carder, to return you to health and to make you improve from the illness that you have in your person, that is in your hand, foot, and mouth, and in good faith, with the help of God, within the next month and a half, in such a way that you will be able to feed yourself with your hand and cut bread. Very specific. What will the patient be able to do? And wear shoes and walk and speak much better than you do now. Does anyone have any ideas what Basso was suffering from? I think Basso had a mild stroke, if you read between the lines here. And I don't think Ruggiero could do anything for him, looking back with modern medicine, although Basso might recover on his own to some extent over 6 weeks, in which case Ruggiero could give credit for. Anyway, the contract is very specific about what Basso shall be able to do. And it says, Ruggiero says, I shall take care of all the expenses that will be necessary for this. And at that time, you shall pay me 7 Genoese lira, and you shall not eat any fruit, beef, pasta, whether boiled or dry, or cabbage. If I do not keep my promises to you, you will not have to give me anything. And I, the aforementioned Basso, promise to you, Ruggiero, to pay you 7 Genoese lira within 3 days after my recovery and improvement. So that's quite a specific contract. And you could imagine that actually it would align incentives quite well. Ruggiero would be powerfully motivated to help Basso. Well, what are some modern analogs of this? Here are some more recent examples for a broad range of conditions. In 1994, Merck offered refunds to patients who had been prescribed finasteride if they required surgery for benign prostatic hyperplasia after a year of treatment. So it's a drug that reduces the size of the prostate gland. Sandoz offered a money-back guarantee for clozapine for the treatment of resistant schizophrenia. Merck promised to refund prescription costs for simvastatin plus diet if simvastatin plus diet did not help lower LDL cholesterol to target concentrations identified by doctors. Novartis had a no cure, no pay initiative for hypertension. Lilly, a no cure, no pay for erectile dysfunction. Bayer, a no cure, no pay for another erectile dysfunction. Merck promised to return money if patients with diabetes, if a patient with diabetes does not meet goals for control after using Januvia. Novartis had a similar thing in 2016 for congestive heart failure. And in 2017, Amgen said it would fully refund money to patients insurer if the patient suffers a heart attack or stroke, despite taking a drug called Repatha to lower cholesterol, which costs $16,000 a year. So the company says, you insure, give us 16 grand every year for your patient, and it will lower the patient's cholesterol. And if the patient nevertheless goes on to have a heart attack or stroke, we'll give you your money back to the insurer. Pretty incredible, actually, if you think about it. And advocates for this public policy idea suggest ways of evaluating the ideal circumstances for such a policy. First of all, you need simple methods that can measure the effect. For example, blood tests. Or the patient or the general practitioner should be able to see the effect for themselves. For example, did they stop smoking? Or could they get an erection? Or was it infections or something like baldness? You could see for yourself, did the drug work or not? And this idea continues to get attention. For example, relatively recently, Bluebird Pharma has suggested that it would charge for its gene therapy for a condition known as thalassemia, which is similar to sickle cell disease, in this way, only if the hemoglobin improved or transfusions declined. Say, give me $1 million for gene therapy in this patient, and I'll return the money if the therapy doesn't work. Now, I don't think this idea is likely to be implemented on any meaningful scale in our society, at least not yet, but I think it's very rational, and I think it would work. And in any case, it's sort of provocative to think about it, as we often like to think about crazy ideas in this class. So we would have to, if we were going to implement these ideas, specify or think about how would we determine efficacy and who would get to decide. And we'd have to even define what we mean by efficacy. And how do patients determine efficacy? And how might that be different than doctors? Returning to the different ways of defining health that we introduced months ago. And maybe there are elements of this idea, such as paying for the quality of care, even if you don't pay for the outcome, that would nevertheless be worth implementing. All right, let me just see where I am here. Hold on. Any questions about that? Okay. Another idea of ways to improve medical care is to pass more laws regulating the actual practice of medicine or patients' interactions with the healthcare system. And we've seen some examples of this in the domain of tobacco and seatbelt use in this class. The issues are different, of course, when we are trying to legislate certain kinds of behavior in doctors, and such laws that mandate changes in doctor behavior as compared to, let's say, patient behavior are rare. And examples include mammogram reporting. There was a crisis a few decades ago when women would have mammograms and their cancer detected on the mammograms, the patient was somehow never informed. It would fall through the cracks. And people were dying because they weren't getting their mammogram report. So the government got involved and said, if you give a woman a mammogram, it's your duty to make sure you find her and tell her the results. So a law that changed medical practice. Another example is advanced directive counseling. If any of you have been hospitalized, I think at any age, you're required now to have your doctors or healthcare providers ask you if you want to complete an advanced directive in case your heart should stop or your breathing should stop. What should they do? And so these types of laws are rare, but they do exist compared to, for example, laws regulating the conduct of medical research, which of course are plentiful. So examples of legislation regarding the specifics of medical practice include vaccination of children, lots of laws specifying what must be done, reporting mammography to patients, reporting of infectious diseases to authorities. Doctors are mandated reporters. If you have syphilis and you see your doctor, the doctor has to inform the public health authorities that you have a contagious disease. Or laws regarding information provision, for example, advanced directives or breast cancer treatment options. Women must be informed of their choices if they have breast cancer. What are the various things that they could do? Now, this is a complicated area, given long-standing concerns with preserving physician professionalism. We want doctors to feel moral responsibility. We want them to feel it's my job to take care of patients. I have a moral duty. But we also want them to exercise judgment and discretion. And we want them to do the right thing as well. So it's difficult when you legislate the practice of medicine. On the one hand, we don't want quacks, and we don't want doctors who withhold information from patients, clearly. On the other hand, we want doctors to feel like they are moral agents and that they are not just bureaucrats, operating equipment in a kind of Emily Martin fashion that we saw early in the class with respect to the delivery of children. So it's complicated, this area. Nevertheless, it's quite clear that the law is a very effective policy tool for changing medical practice and not just patient behavior. Making information more widely available is another possibly low-cost way of improving health and healthcare. And the internet is doing just that. And as a result, is leading to radical changes in the doctor-patient relationship. This is now kind of an old study which looked at the impact of putting information in the hands of patients. It found that 40% of people with internet access use it to get health information. I'm sure every single one of you has Googled something about a health problem that you or a loved one has had. And you read it up and you're like, oh, okay, now I know what's going on with this. 48% of those with a chronic illness felt that internet use improved their understanding of their condition. And 27% of those with a chronic illness felt that the internet use improved their ability to manage their condition by themselves. And increasingly, we're seeing online patient sites and wikis, which are an amazing development, which you guys take for granted, but which, when I was a young doctor in training, if parents came in and they had a young person that wasn't managing their diabetes, like a teenager that wasn't managing their diabetes well, they might say, let me introduce you to another family that has such a teenager so that you guys can support each other and the teenagers might learn from each other. Or if you had a woman that needed breast cancer surgery and she was trying to decide what to do, you might say, well, let me introduce you to a patient from a year ago who might help you understand what the options are. Or two women, one of whom had a mastectomy and one of whom did not, and so you could talk to them. But these were difficult things to arrange. And now, of course, such patients find themselves online. There are support groups that share information about almost every single medical condition, about side effects of drugs, about different treatment choices, about the quality of hospitals and doctors, about other kinds of non-pharmaceutical interventions that might make a difference. And in my eye, this is a phenomenal and positive development, because patients are not stupid by and large about their own conditions. And they are powerfully motivated to make inferences about what truly works. And so they're a source of wisdom oftentimes with these types of conditions. And partly because of this, patients come into the medical office with more knowledge. They can gather experiences and interact with other patients all over the world. They can get non-medical perspectives on their treatments and second guess their doctors. And they can band together to advocate politically for changes in reimbursement and practice. The population of people older than 65 will swell from 35 million in the year 2000 to over 53 million now. And these individuals will, for a variety of reasons, including increased access to medical information, patients' rights movements, for example, the right to die movement that we studied months ago, and the consumer choice movement, these people will bring increased sophistication to their healthcare encounters. Some have even argued that this will accelerate the movement and awareness of self-care and wellness and will irreversibly alter the traditional doctor-patient relationship. I think we're beginning to see some of those transitions where people increasingly, with the assistance or with the availability of internet information, are feeling more agency when it comes to managing their own conditions. In some ways, the internet might even though Illich would have criticized it, given his anti-technology stance, in some ways the internet might even help us to realize the vision articulated by Ivan Illich many lectures ago of putting health and health information into the hands of the people. This is what Illich was arguing for, as you may remember. He didn't like a kind of technocratic, bureaucratized style of medicine that led to people being alienated from their own bodies and from life experience. And ironically, this very modern, hyper-modern invention of the internet might actually help fulfill Illich's atavistic, that means throwback, might help them achieve Illich's atavistic desire to go to a simpler time where doctors weren't necessarily so empowered. Other policies we might implement might direct themselves to patients rather than to doctors, and might be preventative rather than curative in nature. Here is one of my favorite and simplest examples taken from your readings and embodying a nudge. The investigators here simply placed signs in a large mall and watched how they affected 17,901 shoppers over the course of 3 months. It was an ingenious, simple, low-cost experiment where they kind of hid behind a plant in a mall and just watched what happened when they put different signs at the foot of an escalator. And this counted with clickers and with a little tally. Are these men or women? Are they heavy or not heavy? Are they black or are they white? Are they elderly or are they not? And what do they do depending on the kind of sign we randomly put up on that particular day? And what they found was that at baseline, 4.8% of shoppers used the stairs. Most used the escalator. But when they put up a sign that emphasized the health benefits of using the stairs, they nudged the percentage up. People came to the escalator and said, you know what, I'm going to use the stairs. Thank you for that sign, up to 6.9%. And if they emphasized weight control, it was even better, up to 7.2%. And they were even able to detect differential impact according to these basic demographic parameters shown here. So in some ways, These results are too good to be true. Think about the cost effectiveness of this. If each sign and easel cost $60, it would cost less than $200,000 to place a sign at every single regional mall in the United States. And if only 4% of shoppers use the stairs in each of these malls, roughly 1.6 million more Americans would take the stairs each day than before. Of course, this was pre-COVID when malls were open. And the caloric cost of walking up and down 2 flights of stairs each day, which is about 5 calories per flight, would amount to a weight loss of up to 5 pounds for an average man over the course of a year. So with $200,000, I mean, it's almost too good to be true, we could have this huge effect on the, with this little nudge on the obesity epidemic in our society. So it's really worth thinking about simple interventions that we might implement if we're smart and we're creative and we're inventive that might nudge people's behavior to change it in a way that enhances people's safety and health. This is another example. So this is an example of nudging advocated by Thaler and Sunstein in your readings and by others based on basic psychological principles. Nudges are simple changes in structure that affect agency in lightly paternalistic ways. And they are often very ingenious. So this is a little nudge to get people to slow down. And as you're approaching this crosswalk, it looks like, you know, Snoopy and Charlie Brown and Lucy and so on. I forgot what this character's name is. Are walking, but actually, you know, it's just painted flat on the ground. For example, to stop gum from winding up where it does not belong, you can give it a right place, you know? So stick your gum here. Which actor did not star in Ocean's 11? Or stick your gum here. This is Marmite. This is a really gross thing that they eat in England. It's like a yeast extract. I hate it. Stick your gum here. So you give people an alternative, an appealing kind of jokey thing. And that little nudge, you don't say, don't throw out your gum. You provide them with a little nudge that's kind of witty, that has an impact on the behavior that you want. And nudges often exploit social pressure. Take your litter home, other people do. And sometimes the social pressure can involve threats. So here we want to stop public urination, but we highlight the fact that a camera will catch you peeing and we're going to post it on YouTube. So this has a pretty dramatic impact on public urination in this setting. Just a little automatic from photo to YouTube posting nudge. But there's other ways to incentivize staying on target. So this is a nudge in a urinal. Just simply putting in this little target here can incentivize accurate use of a urinal. Or this one dates to when Napoleon was in power. This is a chamber pot, and you could piss on the emperor. By giving you this little nudge, you were more likely to urinate in the right place. And this one is not so subtle. It was an advertisement for Atabrine, an anti-malarial drug, in Papua New Guinea during World War II. These men didn't take their Atabrine. That's a pretty significant nudge. But nudges need to be thought through carefully to involve unintended side effects, as this viral photograph showed. So someone wants to distribute in schools a pencil that says "too cool to do drugs." It's fine when the pencil is brand new, but as you begin to use the pencil, it becomes cool to do drugs, or just drugs, which is really not the nudges that you want. Here's an inventive example from Sweden, similar similar in intent to the placards that were placed in the malls. Now, raise your hands if you've seen this video before, just so I have a sense of how many of you have seen it. Maybe not so many. That's good. Okay, here we go. Now, it was a Volkswagen initiative, but that's fine. Pretty inventive, right? So we could design our built environment with these types of principles in mind, how to make it easier for people to do the right thing, right? And not just, you could take this as an example and now generalize it. And I think it might be quite easy, for instance, to begin to think about what we could do at Yale. Little interventions here and there that would improve the health targets of Yaleys. We might start by asking Yaleys what they think is important with respect to mental health or physical health, for example, and then pick from among those things that might be modifiable in some ways, and then try to come up with nudges that actually might make a difference for Yaleys. And we might design an experiment where we could test it, just like the little placards, for example. And I see no reason why we couldn't have lots and lots of initiatives like that on campus to see how we could improve the health of local students, or ultimately, of course, I'm just using this as an illustration, young Yaleys are pretty healthy already, but you can then generalize it to other parts of the country, people who are poor, people who are chronically ill, and so on. Now, here's an example of how the built environment can be ridiculous. You're going to 24-hour fitness and you're taking the escalator. I mean, there's really no reason to have an escalator here necessarily, or, well, maybe there is for people who can't walk up and down the stairs, but you can begin to think about it. And as we saw earlier in the course, even a slight increase or decrease in the average calorie intake can have huge population level effects. This figure shows that the median of the distribution of estimated energy accumulation that accounts for the observed weight gain of about 2 pounds per year in American 20 to 40-year-olds amounts to only an excess of 15 calories per day, or the flight of stairs we just discussed. In other words, if people just cut back a little bit every day, on average, this has huge population level effects. So signs and environmental nudges could work. But this must sound too optimistic, perhaps it does, for other things that we learned in the class. That is to say that people adapt to environmental stimuli. They might adapt to the signs and come to ignore them, just like cigarette labels. So maybe initially you put the piano tuner, the piano on the stairs, and they're very cool for the first couple of months. And then after a while, most, or perhaps even all, people revert, which means we have to stay inventive in what we are doing. Evidence suggests that physically, socially, and intellectually active lifestyles protect against cognitive decline. And the ability of aging individuals to maintain an active lifestyle might depend on the level of mobility that is enabled by the built environment. Making public transportation more affordable increases transport use and engagement with other human beings among older people. And in the United Kingdom, the older person's free bus pass, which was introduced in 2006, allows older adults to travel for free on public buses throughout the country. This scheme provided a natural experiment to examine how a policy that encourages older people to use public transportation might affect cognitive function. And what they found was that the policy led to an increase in public transport use among older people, as well as higher levels of physical activity and social engagement, and lower levels of obesity, depressive symptoms, and loneliness. The free bus pass might also have benefited cognitive health among older people. For example, social interaction and intellectually stimulating activities require the use of cognitive faculties, which, according to the use it or lose it theory of dementia, has direct impacts on brain structure and function that could protect against cognitive decline. This figure, taken from your readings, shows mean cognitive scores according to age for public transport users and non-users. So what is the mean, what happens? There's a cognitive decline in both groups, but the public transport users, the free bus passes, the people using them or given them are shown in the higher line compared to the lower line. Increased public transport use due to the free bus pass was associated with a 0.346 a percentage point increase in total cognitive function Z-score. Or instead of paying doctors or relying on simple or cheap nudges, maybe we should actually pay patients. Here was a study, and I think it was in your readings, of a $750 incentive, which was very effective and highly cost efficient, as you saw in your readings regarding this randomized controlled trial. The question is, maybe it's better for patients and perhaps even for us to pay patients to quit smoking. So if we give them $750, how likely are they, how much does that increase their odds of having successfully quit, about a year later? And so in the incentive group, the odds ratio was, there were three times higher odds, 3 times the odds of quitting if they were incentivized compared to being in the control group. In the unadjusted model, never mind the adjustment, I should cover that up. The point is, you could triple the odds that someone could successfully quit smoking by paying them $750, so it's worth it. Now, in the case of smoking, in fact, we've used much more than mere signs as a nation. We've had a multifactorial approach to reducing tobacco consumption in our country. We have labels on cigarette packs. We've got excise taxes. We've passed clean air laws. We have laws limiting sales to minors. We have advertising restrictions. We've got counter-marketing and social movements going on. We have done everything we can think of as a nation to tackle the burden and problem of public health of tobacco consumption. And it's quite likely that a similar broad effort is going to be needed for other types of health problems. We're going to face this with COVID, for example, with vaccine hesitancy. And we're going to need all kinds of incentives, like every tool in our armamentarium, in order to effectively deal with this public health problem. Getting vaccinated for COVID is very analogous to the problem of secondhand smoke. So we're going to need laws, for example, about whether people, whether you need to be employed. Whether employers can mandate vaccination for work or for travel. We're going to need, not restrictions on advertising, but we may need counter marketing or taxes or labels or other kinds of inventive approaches to persuading people and nudging people, and in some cases forcing people to do the right thing, just like we have done with smoking. But perhaps some policies could actually approximate the removal of the handle on the Broad Street pump that we also learned about a few lectures ago. Such interventions, if we could come up with them, might so radically affect structure that they cure a condition. In other words, if we really think inventively about the structure and agency problem in public health, there may be certain things we can do, like removing the handle from the Broad Street pump, that radically change the course of a public health problem like an epidemic. So if we are serious about improving health, we must see that increasing access to and use of medical care, however commendable this goal is for pragmatic or moral reasons, is not the same as health promotion. It's not just about insurance. It's not just about whether you see doctors or can use a hospital. And in fact, we need to see that medical care is not the same thing as health improvement, and that our system does poorly when health and medicine differ. And a better system would pay for health improvement rather than simply service provision. The current system does not pay for many things of great value. And as you may have seen, for example, during the COVID crisis, hospitals lost money during a time of pandemic because they made money caring for, doing x-rays and tests and other things of often questionable utility in many patients, and weren't paid so much for taking care of people who were, dying of a pandemic disease. This was not a rational way to organize a healthcare system and a payment system that supports it. It's again the problem of underinvestment in public goods, and it's going to require ongoing collective action to redress this. Okay. Any questions? Ananya.
Yeah, just a quick question about one of the last points that you summarized. When you say that like our system does poorly when medicine and health differ, were you referring to that as like a isolated thing that happens, or just like generally like how our system of health like splits up those things and how that's not good?
My point there, it's a good question. My point there is to highlight the fact that oftentimes we think that medical care is the cure, or that if we pay for something, it must be worthwhile. Or often we pay for things that, even if we know they're not worthwhile, and that we don't align medical care with health improvement. So a simple example might be giving people antibiotic prescriptions and paying doctors who do that, even if the patient has a viral illness. So you go to the doctor thinks you probably have a viral illness, you don't have a bacterial illness. You, however, expect the doctor to write a prescription. The doctor feels, if I don't give her a prescription, she might go see another doctor in the future. Even though I, the doctor, know that she will not benefit from this prescription, I'm going to prescribe her this antibiotic for her infection, even though the antibiotic won't help. And the insurance company pays the doctor, or you pay the doctor for this service. That's medical care not aligned with health, being compensated or paid for. And there are many, many examples of that are, more Baroque, where we pay richly for things that really aren't very beneficial. Very early in the course, highlighting some black-white differences in healthcare service provision, I listed a few things that, are richly compensated. When I presented those data, I was highlighting the racial difference in the service provision. But actually, if you go back and look at that list, you'll find a whole bunch of stuff that is richly compensated that actually doesn't help patients. We're not advancing health when we provide those kinds of pay for those procedures. Other questions? Okay, here's a very simple question. Who is worn out by Zooming at the end of this semester? It's very low energy, isn't it? To do Zooming, I feel sorry. I feel sorry for myself, but I feel even more sorry for you guys. You're not in class. It's not the same. And you just Zoom all day long. It sucks. I get it. Are you learning? You're learning. All right. Any questions before I let you go? Tirthraj, is that a leftover hand, or do you have a question? You're on mute. Leftover hand. Okay. Oh, no. One last question. Nicholas, yes.
Hi. Yeah, sorry. I just had a quick question. I know earlier in the semester we read, I think it was like how a pacemaker like ended my father's life. And we talked a lot about like over medicalization. But then today in class, we also learned like.
Hold on, Nicholas. That's actually a really good example answering one of your classmates' question earlier. Yes, and like medicine and health not aligned, right, in the pacemaker. Thank you for reminding me of that. Go on, I'm sorry.
Oh yeah, no worries. But I guess I was just interested about like that with like the tension of like the insurers switching to like no cure, no pay, and like if this new development has been like counteracting over medicalization, or like how the two interact.
It would counteract over medicalization because, for example, in the pacemaker example, like if the patient died as a result of the pacemaker, the insurer would be quite motivated not to have pacemakers placed needlessly in patients. We would only allocate pacemakers to patients for whom there's actually a net benefit and only pay accordingly. So I actually think that aligning the financial incentives would be extremely effective here at restraining pointless, unnecessary, potentially harmful medical care. Did I answer your question?
Yeah. I was just like curious because then it seemed, or I know that article was written like a couple years ago. So I guess I'm like a little bit confused about like recent developments and like where they like interact.
No, I don't think the landscape has changed that much in the last couple of years. People continue to toy with the prescription drugs, as I talked about it, 15 or 20 minutes ago, with specific little cases of this. I didn't discuss this today, but there's also a broader design with the health maintenance organizations where you try to align the incentives so that the HMO, they're called health maintenance organization because they're trying to not just treat you when you're sick, but keep you well. So they have an incentive to somehow provide services that prevent you from getting ill. And in so doing, they benefit, they capture part of the profit and their patient-based benefits. So there are many aspects of our healthcare system where people are trying to align the financial incentives better. David and Ken.
Nick's question made me think of a related question, and it's been a while since I read that article that we had to read for earlier, but if I remember correctly, like it was kind of like a life extension, like it was just like keeping the dad alive, but like he wasn't doing too hot at all. And so how would kind of the idea of like paying, like it's work. So I feel like that's a situation where it might fail because it's working if it keeps the dad alive.
Well, no, because you would try to align it or make it so that the quality of life was a factor as well. Like, for example, you would say, you know, if the patient, I had patients like this when I was a young doctor in training where their brain had died, but their heart kept beating and would have died, but for the pacemaker. They were like zombie patients where the heart kept beating. And it was very painful to get the family to remove the pacemaker, which had previously been seen as a life-saving, life-affirming kind of technology, and now was seen as, you know, but who wants to say, okay, go and stop his heart? Because once you stop the pacemaker, the heart would stop beating. Very complicated clinical situation. But the idea is that you want to align the incentives. Ken, Kenneth.
So what in your view is, you know, are some of the obstacles facing like reform in favor of paying for outcomes or paying for quality? That's my first question. The second question is it, you know, kind of related, is it the difficulty with coming up with objective measures for, you know, what are good outcomes? Because I mean, I would imagine some, you know, some, I guess, experiences of health would be based on subjective experiences such as, oh, you know, well, this state is worse than that state. So how can we say, you know, oh, this treatment worked versus that treatment didn't work?
There are many difficulties. You've highlighted one of them, which is many outcomes are subjective. You know, how would we know whether psychotherapy helped the patient, for example, or maybe we gave them a medicine that lowered their cholesterol and you had a heart attack anyway, but it's really not our fault. We should still get paid. You know, it's just chance. You know, how would we account for probabilistic stuff, subjectivity that you mentioned, or very complicated chains of causation or complicated medical problems? Just to be clear, I'm not advocating, I don't want you to leave this lecture thinking that I think that we should only pay for outcomes. I'm not advocating that position. I don't necessarily think I certainly don't think that's right in all circumstances. But I am saying that thinking about that, thinking about what it would mean to pay for outcomes gives you kind of insight into what is and is not working in our healthcare system and in insurance. So, and there may in fact be specialized applications where it is a good policy to implement that. But it's not easy. And I mentioned earlier in lecture, I said, here are some illustrative situations where it might be possible in a very focused way to use such an idea. Okay, so last lecture is very important. It's on Thursday. I strongly encourage you to come, and it will begin a few minutes late, and we will not take up the whole time next time for the last lecture. Thank you, guys. See you in a couple of days.
Thank you.
You're welcome.
Thank you.
Thank you.